Hello everyone. So after we covered up all the relevant details in the spinal neuroanatomy and spinal cord anatomy, today we can move on to the actual surgical steps involved in the spinal cord exposure. So today I'll walk you through the major setup that is required in order to do the spinal surgeries, because that's very important because it's pretty different from the cranial surgery setup. So more or less, at least for the cervical vertebra exposure, you can use the stereotactic setup, which is useful for brain surgery. But for the thoracic vertebra and the lumbar vertebra, especially if it involves the spinal cord injury models, the setup is pretty different and the exposure is different, and how you handle the spinal cord and spinal vertebra is pretty different from the cranial neurosurgical approaches. So with that, this is the outline that we are planning to have. I'll walk you through the instrument stabilization system and the retractors, because that's form the very important aspect in the entire spinal surgery. As I said earlier, we are dealing with a very focal part of the spinal cord, and you're trying to expose a small segment of the spinal cord to create injury or to inject viral vehicles, or you want to try injecting drugs, or trying even to drain the CSF and do microdialysis for whatever spinal neurosurgical procedure that you're planning. The stabilization system and retractors are very important to make sure the spinal cord is not injured during the surgery, just so similar to the cranial surgery. So anything we are dealing with the neural system, stabilization system and retractors are very important, unlike the other areas of the rodent body. So once we deal with the stabilization system and retractors, then we'll take go through the different sections of the spinal skeletal system, cervical vertebra and thoracic vertebra exposure. As I said, it's different. And then we look at the creation of spinal windows, just similar to the cranial windows that we discussed. And then briefly about the spinal cord injury model, which is one of the most common models that are studied. And then briefly I take you through the microelectrode implantation as well, and that those steps are pretty common for even the other strategies with slight improvisation. All right. So the first half of the session I'll deal with the setup itself. So the first part is the spinal surgery instruments. So if you look at the instruments that are involved in spinal surgery, and this is slightly larger and you have more bone instruments than the cranial surgeries. So here from top to bottom we have listed as steel clip applier, mosquito clamp, but if you want to go as per the exposure, then the first thing that would come is the knife there, that is the handle with the blade, and then comes the dissecting scissors, and then you have tooth forceps and non-tooth forceps. Then you have the bone rongers. Once a dissection is made in the muscle, you will be doing the laminectomy using these bone rongers. So you can see how heavy this instrument is, but however the tip of the instrument is pretty fine and rigid and pretty sharp. So but you need to see that if you are not using the drill, even drills can be used to do the laminectomy. In fact, it is much more safer to use the drill, but only thing is there is a learning curve involved in the drilling for spinal surgeries, and which is pretty different from the cranial surgery drillings. So if you are well versed and if you are good at using the drills, then that's the best instrument for laminectomy. If suppose laminectomy is if the drilling is difficult, or if you don't have the drill set up, then only I would recommend to use these rongers to remove the lamina or the spinous process. Spinous process is fine because you still have the lamina intact covering the spinal cord. And when you use this instrument, obviously the spinal entire system will move along with your force to remove the bone. So that's exactly the reason why we need a stabilization setup where the spine is fixed in some point at some point, so that there is a counter traction on the rodent body when you remove a segment of the spinal canal. Alright, then obviously those instruments of micro scissor and forceps, and once the surgery is over you will be using the stainless steel clips to close the wound. Those are similar. Alright. So most important part is that the spinal stabilization system. So I'm using the stabilization system here, not the stereotactic system. You really don't need a stereotactic system if you know which level you're targeting, and if you're really making a pretty large incision, exposing the whole length of the thoracic vertebra or lumbar vertebra, you really don't need a stereotactic system. It's not that commonly used. The stereotactic atlases are not that commonly used, and for a simple reason that the cord varies a lot, and then those coordinates even are going to be arbitrary because of the shift, because of the movement. The maintenance of the stereotactic position is very difficult as compared to the cranial surgeries. And of course the atlases are available even for stereotactic surgeries of the spinal cord, but then it is not used that frequently as compared to the cranial surgery because of the similarities between the cord segments. Even if you are one segment higher or lower, we can still manage unless your experimental outcome is that rigid and you really need a specific segments that are involved. So only then the accuracy matters that much in the spinal cord surgeries. So what you're seeing here is the stabilization system. So clamps and retractors are more important. These are self-retaining retractors. Once the skin incision is made, imagine the rat lying down in the prone position here. Alright. So once you make the incision and then expose it, the skin will be held initially. Later when you go in the depth, mainly to hold the muscle apart. So that's the importance of having these clamps. And then not only that, you can even bring it closer and have a rigid fixation of the spinous process. Alright. So I hope you all remember the spinal canal anatomy that we discussed. The spinous process of the vertebra will be fixed using these at 2 points, and in the center you can do the laminectomy. When it's fixed at 2 rigid points, you can do the laminectomy, remove the bone, expose the spinal cord, and you can even use the impactors. Alright, so that is one way of fixing it. The other way, on the right side you can see that there are 2 rigid fixators on both sides which are brought to the midline and then fixed on to the lateral edge of the spinal canal, or for that matter this will be closer to the transverse process. If you remember the anatomy, this is the spinous process and that is the transverse process, that will be the spinal canal and then the body. So that is how it lies, and so this will go under the transverse process. Specifically, if possible, after dissecting the muscle you can bring it closer and expose the transverse process and get these rigid fixating bars underneath the transverse process, so that the spinal cord or the spinal column does not move with the steps of laminectomy, where you will be using the heavy rongers to remove the lamina, or even while using the drills you do not want this spinal canal which is otherwise mobile to move around. So this sort of stabilization system is pretty important before we proceed to the next step. Alright. So here is the system in comparison, various levels and various technique of using the fixators and the clamps. So what you are seeing here is the movement of the spinal column when you use the impactor from top. So this is the classical spinal cord injury model, wherein you want to induce the injury by contusing the cord. It's cord contusion. Something comes and hits the cord. In this case it is impactor, which is actually a measured one, which will be dealing in next few slides. But what I want you all to put the attention is for these clamps, area of fixation. Closer to the area of surgery, less will be the movement. As you can see, when the clamp is applied to the top and bottom, the movement is much more than when it is next to the laminectomy level. However, if you see, the movement is absolutely nil when the fixating bar goes underneath the transverse process. Alright, this is spinous process. So this is the reason why we always tend to use these fixations under the transverse process, unless it is mice and very difficult to expose this particular transverse process. Only then you will be resorting to use the clamp onto the spinous process above and below the level of laminectomy. Here is where the laminectomy will be performed. I hope you all remember what is laminectomy. Lamina is the covering the posterior arch of the vertebra. This is the spinal canal, and that is the body of the vertebra. That is the transverse process, and that is the spinous process. Alright. So we need to remove the lamina to expose the spinal canal, within which there is a spinal cord sitting in the head shape, grey matter and white matter. Alright. So that is how the fixations are recommended, and this is the preferred way of fixating the spinal column when you are using the injury models. For that matter, any laminectomy procedure, this is the best way of fixation. So what sort of setup is used to achieve that sort of fixation under the transverse process is this. You can see this is the trough of the U-shaped rat container which lies, and then once you expose the spinal column, you will expose the spinous process first after making the skin incision, then remove the muscles on the sides, and then you will have the transverse process there. So get these bars under the transverse process, and that gives the rigid fixation. You can see there is a good serrated edges to grasp the lateral vertebral processes or transverse processes. Alright. So that is very important, and here is the picture where the surgery is in progress with this container which is holding the rat, and then the fixators are gone in under the transverse process. This has been put under the transverse process after the exposure, and then you have this vibrating assembly wherein there is an impactor which can go and cause the cord injury. Alright. So you can have any sort of instrument. For example, here they use the blade and blade holder wherein you can make an incision in the cord. So there are various models, various methodologies available to create spinal cord injury model. In this case they are using the blade where they are literally cutting the cord and inducing it, but then the natural injuries are all by using the impactors which will reflect the natural traumatic cord injuries in humans. So there are pros and cons for various injury models, and the other way is to grasp the spinous process by using such a stabilization system. There is another modified stabilizer system which concentrates again on the spinous process. If suppose you need a larger area of exposure and then you want to do the laminectomy, because when you use the transverse process which is coming from the side, maybe it hinders the other surgical steps, and this is one way where you can modify and hold the spinous process. But then there are chances that it can slip downward no matter how tight the grip is when there is vertical force involved. If there are no vertical force involved, if it is just for the laminectomy, then this is very convenient to use, because all you have to do is to expose the spinous process above and below the level of interest, and then bring in the stabilization system which grasp the spinous process. So this is good enough for small injections or microdialysis, or something where the spinal cord is handled more than the injury models. Now the impactor injury models is one thing where the spinal column is going to move more. There you definitely need a much more rigid fixation, and that is where you use those serrated bars to fix it under the transverse process. So this is another stabilization system shown here, which the beauty of this stabilization system is that there are retractors involved, and which will help immensely in the exposure. Alright. So this is one of the cervicothoracic cord exposure, wherein the oral point that is below the auricle has been used as the fixation points, or something similar to the cranial stabilization. And what you are seeing here is the retractors that can be modified as per the need, wherein the skin and the muscles are held out of the surgical areas. So that retraction is an amazing step which will clear the exposure of the spinal cord and make sure the tissue does not interfere with any of the surgical steps. Unwanted tissue will not hinder the progress of the surgery. So that is another good spinal stabilization system. So this is what I was talking to you all about. When you are trying to use the impactor or an impounder, then it is better to have a very good stabilization system. So this is another manual manual impounder or impactor, where you can use the metal rod to create a spinal cord injury. So these forceps are used to grasp the spinous process again, above and below. So this is another spinal stabilization system commonly used, and the other one which I showed where the transverse process is grasped is an improvisation from this basic system. But here the impounder is sort of blend into the entire stabilization system. So it is like one system wherein there is a fixation which can be moved freely in different directions and axes, so that irrespective of the size of the rodent that you are handling, be it a mice or a rat, this particular system can be used to stabilize the spinous process. So this is the automated impactor system. There is a similar stabilization system where the spinous process will be held by this, and the laminectomy has been performed, the spinal cord has been exposed. Let us say that is a rat, and that is how this is going to come and hit the cord and create the spinal cord injury model. So these are the automated impactor. Similarly here, wherein the exact amount of force can be calibrated and then adjusted, and only that specific force will be delivered to create a controlled contusion of the rat's spinal cord. Unlike the mechanical impactor, where the accuracy is little low and the injury may be more than what is expected. Alright. So the next remaining part of the presentation is about the cervical vertebrae exposure. Alright. So then again here, for spinal surgery the positioning is entirely different. You need to make sure the area of importance or the area that you need to expose should be at a higher level. Alright. And if you all remember the discussion that there is a cervical lordosis, the curve of the spine is this way, alright, that is the head of the rat, and that is a skeletal system, and then there is a thoracic kyphosis, and then there is again a slight downward dip, and then the tail comes. That is how the natural curve of the spine system is. So if you are doing a surgery here, then you have to make sure that cervical vertebra is on top, alright. Otherwise what will happen, there is crowding of vertebra happening, and all the spinous process will be together, and it is very difficult to expose and do the laminectomy, for a simple reason that you can consider this as multiple rings which are crowded like that. That is because of the natural process of, natural curve of the cervical spine. So, you want this to be outwardly arranged so that the spinal canal which is in the center is easier to expose after removing the lamina of the exposed vertebra. So, in order to do that, you need to give a wedge or a pillow as shown on the right hand side, where the pillow gets the curve and makes it kyphotic that way. So, what will happen? The ring will start organizing that way, alright. So, from this to this change is brought out by the wedge, wherein the spinous process opens up and the spinal canal is easier to view. Not only that, you can even pass your instrument ronger or drill easily and remove the spinous process and lamina and expose the spinal cord. For example, if you want to use the drill here or use the bone ronger, you really do not have an edge of the bone to handle, and that is the whole importance of these positioning. Whereas in thoracic vertebra, this problem does not arise because naturally it is kyphotic, but however you need some rigid support under the rat, and also make sure that that does not compress too much. For example, the thorax is coming in contact with this pillow or wedge. It should not be overdone so that there is a compression of the chest wall and it hinders with the breathing of the rat. And for the same reason, you are not supposed to keep your hand or any sort of instruments on the body of the rat during the surgery. That is very, very important, because that would compromise the chest wall expansion that way and would lead to oxygenation deficiency. And that is again the reason why you need to do the monitoring of vitals. So, this will be dealt in detail in the anesthesia section, wherein we will be discussing all the vital monitoring steps and vital monitoring apparatuses. So, that is briefly about the positioning required for the cervical vertebrae exposure. So, once the positioning is done, and now you are good to go for the exposure of the vertebra. So, the incision technique is the same. You will be indenting or piercing it with the tip of the surgical knife, and then use the belly and then make a slit. Alright, that technique is the same. When you do that, keep your index finger and the thumb on both the sides, and then spread it apart as you make the incision, so that you know how far deep you have gone with the incision. Alright. So, once you do that in the cervical level, this is the muscle that comes into view, which is the trapezius muscle, which controls the neck movement, and then there is some adipose tissue, subcutaneous fat that comes into view. These are the self-retaining retractors, which are different in different stabilization system. One of the commonly used retractors are like something like a cat's paw retractors, alright. So, those retractors will be used to the edges, and then these exposure is maintained till the exposure of the muscle. So, once that is exposed, the first bony prominence that is seen is always the T2 spinous process. In human it is always C7 vertebra, in rat it is T2 spinous process. That is how you know at what level you are before you start to expose different lamina or different vertebrae, alright. So, once you see this spinous process, you are confident enough to proceed with the exposure of the remaining vertebra. If you do not see, suppose you stopped your incision there and you expose it and you will see only muscle without T2, then you need to extend your incision until you see the T2 spinous process. That is your whole idea, where T2 can be used as a very good reference landmark, alright. So, once the T2 is seen, we can proceed and make an incision or split the muscle. If you go in the midline, you will get a beautiful avascular plane. Avascular refers to absence of major blood supply, wherein you have only loose areolar tissue. Okay. So these are some of the tissue terminologies where you have a ruse without major prominent blood vessel which you will injure, and if you go through the muscle, that definitely leads to a lot of blood loss. And for a small animal as low as like for example 20 gram or 30 gram animals, pups, that sort of a blood loss is enough to cause hypovolemic shock. That again we will be dealing with when we are discussing the anesthesia part. So it's very important that blood loss is kept minimum. So if you are in the strict midline, you will ensure that it goes through the avascular plane, and then you can expose the vertebra as shown here. So that was the midline, alright. So from the T2 you can count upwards T1, 7, 6, 5, 4. So if you want to create a spinal cord injury model at C5 level, you need to remove this lamina either by using a drill, and in the previous sessions you all learned how to use a drill. As you can see, these bones are really slender and very soft compared to the cranial bones, and of course the hardness of the bone depends on the age of the rat, or if it is a mice, if it is going to be soft, where you can cut it with the scissor itself, sometimes heavy scissors, or you can use the bone raunger to make a nick on both the edges and lift up this vertebra so that the spinal cord will come into view, alright. So this is how the surgery progress. Once you expose the vertebra, this is zoomed in view of this area. This area has been zoomed in where all the surgeries are best performed under microscope. That I am not changing it. I am presuming that you will know that we will be using microscope for all the surgeries, for a simple reason that these vertebrae are pretty small to appreciate without the microscope, and especially when you do the bone work, and if you are not careful enough, you will injure the spinal cord before the experiment experiment begins. So it is very important that every single step is performed using the microscope, and that again needs a lot of hand-eye coordination exercise. So once you are good at using the microscope, then these steps becomes easy. And so what I was saying is that this area is zoomed in to expose the lamina at C4, C5 and C6 level, somewhere that there was a T2. So the orientation is this way: T2, T1, C7, C6, C5 and C4. That is the spinous process. That is how the rat is lying, rostral, caudal, alright. This is how the lie, and this is called a coronal orientation. Okay. So this is the dorsum, and we are going above downwards as we approach. So the skin has been retracted, muscle has been retracted, and the spinous process has been exposed, and this is the lamina that we have exposed. So using a drill or the bone rongers, you open that much of the lamina, alright. You start the drill and then continue the way you did it for the craniotomy, or use the bone ronger and make a sharp cut here and medially. This is lateral, this is medial. Closer to the midline is medial, away from the midline is lateral. And when you do that, then you will see the spinal cord, and this is the blood supply that you have learnt in the previous anatomy session, because those will be the roots, alright. This is the midline. As you remember, the blood supply on the dorsum, on the top surface of the spinal cord, comes from the root and then climbs up onto the surface and then supplies the dorsum surface of the spinal cord. So once the dura is exposed, then you can remove that dura if your experiment involves some injections or microdialysis or any sort of experiment which requires exposure of the cord. In this case, because it was a spinal cord injury model, you can remove the dura to appreciate the contusional changes that are going to happen, or even maintain the dura and then bring your impounder after this step wherein it causes this contusion. If you can compare the post laminectomy and post spinal cord injury picture, you can see the dark coloration, discoloration here, alright. That is sort of an ecchymosis or a contusional hemorrhage, to use it in a medical terminology, where there is a contusion caused by the impounder which comes and contuses the spinal cord, alright. So, that is how the spinal cord injury model is created. So, concludes today's session. So, we are trying to consider the entire spinal surgical process, in which we have exposed the cervical vertebra, and as an example we have done the spinal cord injury model. We have operated on and created a spinal cord injury model at the level of C5, alright. So, that covers the entire stabilization system and the cervical vertebra exposure. In the next session we will deal with the thoracic vertebra exposure, and then of course micro electrode implantation, how it is done, those particular steps which are little different from these surgeries. So, with that we will be completing the spinal surgery. In next session we will take up those other sections and discuss it in detail. Thank you.